Welcome to the next episode of Endoscopy Essentials. It's Barbara Bastiaansen from Amsterdam again. Welcome, Barbara. We have learned in the last episode how you got into this topic. It's a fascinating topic. It's very narrow, but very, very clinically relevant. It's early colorectal or even early rectal cancer where you're focusing.
Yeah.
And I think the overarching principle is organ preservation.
Right.
I would like to start from scratch.
Right.
Because when you sit in tumor boards, sometimes it's a little bit unclear what's early cancer. Is that mucosal cancer, like in the esophagus, or so enlighten us, please.
Yeah, I think that's a good point. That's a good point to really stress that when we talk about T1 colorectal cancer, it's cancer invading the submucosal space. So mucosal cancer, I think we should avoid that term. It's high-grade dysplasia, as we call it. But so if we talk about T1 colorectal cancer, it's cancer.
Submucosal. Yeah.
It's submucosal. Yeah.
There's this huge
invading.
battle among Western and Eastern histopathologists whether it's high-grade or mucosal cancer.
Yeah.
But I think biologically it's not metastasizing, so it doesn't matter so much.
It's probably the same, mucosal cancer or high-grade dysplasia.
In the colon, as opposed to stomach and esophagus.
Yeah.
So that's a big thing, but I think we can't stress it enough. We apologize to our viewers if it's too much. But Okay, so is that frequent, early colorectal cancer, or more frequent recently?
Yeah, since we introduced bowel cancer screening programs, it's completely swapped the stage distribution of colorectal cancers that are found, and we know that within screening, almost half of all cancers being detected are actually a T1 cancer now. So it's the most, stage 1 is the most frequently encountered stage of detected cancers now within screening. So it's very relevant. Also, it's very relevant because we know that the overall risk of lymph node metastasis is around 10% for T1 colorectal cancers, meaning that if we can remove them radically, there's a significant chance of being cured.
Organ preservation.
Right.
And it also means 90% don't have lymph node metastases.
That's right. Yes.
And that's one of the challenges, right?
Overall, because 90% is the overall, but of course it varies amongst risk factors. I mean, the best we have is on risk assessment is our histology, and that we know that within risk factors there's a huge variability on the risk of lymph node metastasis. So it goes from less than around 2% up to, in very ugly T1 cancers, up to maybe 25%. Yeah.
And we have to find out which is which.
Yes.
But surgery, I think we try to avoid surgery. Why?
Yeah, especially, of course, in the rectum, surgery comes with, we pay quite a high price for rectal surgery. Of course, comes with quite high morbidity rates, up to 30%, and there's a risk of stoma, and there's functional loss with rectal surgery, and we should also not forget that after oncologic surgery for early rectal cancer, it still does not prevent cancer recurrence in all cases. So 4% still recurs despite oncological rectal surgery. Yeah. And that, of course, we need to balance then the risk. Okay, if we only do a local excision, what is the risk of cancer recurrence, and does that lead to cancer-related death? And we need to find the balance better than we do today, I think, because after a radical excision of an early rectal cancer, I mean, to still do surgery with such high impact for patients and their quality of life, I think we should, at least have a debate about that. Then, what is the additional value?
Absolutely. I think we had this in some previous podcasts, that there are sometimes very strict guidelines or rules, which are based on the fact that we want to avoid that the cancer kills the patient, but we accept that we kill the patient in a much higher percentage, and there's something wrong. So I think we have to rethink that balance, and that's the very topic here in the rectum, right?
Yes, especially in the rectum. Absolutely. So if we look at guidelines, this is what they tell us. So we differentiate T1 rectal cancer into low risk or high risk, and then high risk is already if you have one of those histological criteria, like depth of invasion, more than 1,000 micrometers into the submucosa, of course poor differentiation, or lymphovascular invasion or high-grade tumor budding. If one of those criteria are present, we call it a high-risk T1 cancer, and then guidelines direct us into surgery.
So the endoscopic intervention was in vain?
Yes.
Or would be in vain?
Yeah.
But again, the level is very low, I think. So the oncologic risk should be as low as possible.
Yes.
But, so we have to redefine. So the question we are asking ourselves is, why do we do surgery and what happens? Yeah. And you're a fan of data, right? So show us what happens. So you have this nice endoscopic resection.
Yes.
It's a high-risk cancer and patient automatically goes to surgery.
If they're fit for surgery, then that's what guidelines tell us. And we should remember that surgery is directed into, of course, the local regional part, because additional surgery affects the risk of local recurrence, of course, because it's surgery of the mesorectum, but it does not prevent distant.
Exactly.
Yeah.
So it's the local tumor and lymph nodes?
Yes.
Right. So is there any benefit if you do that?
Yeah, well, that's a big question, because now it's accumulating data are showing up that indeed surgery prevents local recurrence, local regional recurrence, but does not prevent the distant recurrence. And we also know that patients with distant recurrence often do not have lymph node metastasis. It's two different things. Yeah, very often. And there's even people who believe that we need the lymph nodes to educate the immune system, which of course affects also the risk of prevents maybe distant recurrence. That's for example this study of a French group. It is an emulated target trial, and that clearly showed that indeed the risk of dying of cancer is not different between patients who underwent additional completion surgery or are kept under surveillance.
So that's local resection, watch and wait?
Yes.
Versus local resection followed by surgery because of high risk?
Exactly.
And no difference?
From this, no.
Yeah.
No difference.
Okay. And an emulated trial is kind of retrospective data, but
true.
It's a similar sort of simulation of a randomized approach.
That's right. Yeah.
So not as good as a prospective randomized trial.
No.
But
which is very difficult to I think to perform for this question. But it's it's coming close. Yeah.
But we have more studies here.
Yes, there's also a study from a Japanese group showing exactly the same. So if you look at this slide, you see that the cancer-specific survival in both groups, so local excision plus surgery or local excision alone, does not differ.
And it's very high anyway, huh? 99 point something.
Yeah, exactly.
Oh, okay.
Yeah. And also so this is a systematic review concerning only rectal cases. So the other studies are colorectal. This is only rectal, and also shows that that actually the risk of distant recurrence doesn't differ for patients who underwent additional TME surgery, or if you just keep them under strict surveillance and only go for salvage surgery when the cancer recurs, which only recurs, of course, in a very small proportion of patients. But then there's also in this study there's no difference, so that is hopeful.
It is. I mean, watch and wait. You're doing this a lot. What's your experience in patients? Do they accept this, or are they fearful and they I would rather like to have more aggressive oncologic treatment.
Yeah.
What's your experience?
Well, for rectal cancer, of course, it's an interesting topic, and we should find out how exactly is the fear of cancer recurrence in patients. But my experience when you talk to patients, and of course they speak to the surgeons as well as speak to myself, and no, they like it. First of all, of course, to avoid potentially the surgery, but also, it's a good feeling. You keep a close look on how I'm doing. Yeah.
I'm not have a devastating surgery and then go away, but
and it's also not that intense. The surveillance schedule is not like being in the hospital every 2 months. I mean, it's for rectal cancer, it's the first 2 years, it's every half year, so 6 months, and then in the 3 years thereafter only yearly. So it's not extremely intense.
And for endoscopy, you probably don't need a colon prep every time.
No.
So that's also a significant point.
Yeah.
Okay, so we have accumulating evidence, and you said it's local versus distant. How is that distributed?
Yeah, if you look at, the main recurrence risk is local regional.
So here's the study which differentiates, right, between local and distant recurrence?
Yes. Yes, this is indeed, actually it's the same findings that if the cancer recurs after a local excision, it mainly is local regional, and that is of course affected by TME surgery, but the distant recurrence doesn't differ at all.
And in absolute numbers, I mean there are always the issue of relative percentages and absolute percentages.
Yeah.
In absolute numbers, the difference of local recurrence is not massive, huh?
No.
As we can see here.
Yeah.
Okay, so we can tell patients, okay, the risk that you have a liver metastasis is not increased by what I'm doing. So if we're doing watch and wait, we'll pick up the recurrence early, and then we can still do surgery.
That's the big question. Yeah, that's something we need to find out. Is indeed, are we early enough to prevent, of course, a cancer spread?
So this is ongoing research.
Yes. Yeah.
So another question endoscopists have: can we stratify the lesions? And I think we're now focusing on rectal lesions, right? Because that's where surgery is more relevant, etc.
Yeah.
Oh, many lesions. I don't want to go into like guessing, but you will tell us. Is it possible or not? Are there certain endoscopic criteria?
Yes, of course. I think the optical diagnostic criteria with using advanced, advanced technique is getting better, and we're quite good in differentiating, of course, benign lesions from invasive lesions. For example, we use the JNET classification system, and as you can see, 2A is a completely benign lesion. 2B is maybe high-grade dysplasia, maybe early invasive cancer, and if you look at the sensitivity. We're quite good in seeing cancer when it's obvious, but to be honest, if it is a cancer, to estimate the invasion depth is, I think, still very difficult and not good enough. I
mean, these figures are not brilliant,
no,
right? There are, I think, European and Japanese experts.
That's right.
And both were not brilliant, or were the Japanese much better?
Not such a big difference.
Not such a big difference.
No significant difference. So no, it's not. It's not. No, it's not perfect. No.
Well, I would say it's not even good, but that's a matter of interpretation.
Okay.
So it doesn't help. And if you see all these pictures, what's your first reaction?
It needs to come out.
It needs to come out.
It needs to come out to know.
But how?
In a safe way, of course.
In a safe way.
Yeah, exactly.
So please explain us.
Yeah.
So now here's the JNET for those of us who are not completely familiar. Everybody's talking about JNET, but we have seen the data. That's type 1, 2A, and that there's some correlation, obviously.
Yes. So we look at the vessel pattern and of course the surface pattern. And then it differentiates benign or non-dysplastic lesion type 1, 2A, completely benign dysplastic lesions, and then 2B it gets a little bit can still half can be still benign, half will be more deep invasive, so not so specific. And then type 3 is the obvious cancer with a deeper invasion.
The bad guy.
The bad guy. Yeah. Well, how bad? Yeah. Because does it really matter how deep the lesion is? That's the question. And I think already has been shown by many papers with very good histology. I mean, prospective and retrospective cohorts, but very dedicated histology, showing that if you only have a deep invasive lesion without other risk factors, then actually the risk of lymph node metastasis is really low, as you can see from this figure. It's really somewhere around 2%.
So that means it doesn't matter so much, but maybe we can go to the pictures and have a closer look, because many people are standing in front of those lesions saying, what is it? Is Janet so, and how deep is it, and should I send it to the surgeon?
Yeah.
So maybe you can enlighten us a little bit.
So it is difficult to see the depth of invasion. I mean, if I show you these pictures here, the left image and the right image, then would you be able to see?
I'm not a believer anyway, and
you're not, but you see it. You see it's irregular.
They both look ugly.
Yeah. So you see there's something wrong in this polyp, but it's very difficult. Yeah. So you see a slight surface depression in the right image. You see some extreme irregular vessels on the left image, but but not a clear demarcated depression in the left image. I show you so the left image is a deep invasive cancer, and the right image is only superficial. We can be wrong. We can be wrong easily in this picture. Huh? For example, this very tiny lesion on the left side, there's a clear demarcated area of depression, but the other lesion on the right is much bigger. It has a nodule. It has this white plaque in the center that you cannot rinse off. I would say, naturally, if I look at it in a glance, you would say the right one is the ugly one. Well, it's not. The right one is the SM1, and the left one is touching the muscle. So it's difficult. Yeah, it's difficult.
No, I couldn't agree more. So you don't have to convince me, but I think that's common assumption that we can see from the surface how deep the tumor goes.
Yeah, no,
but there are more realistic data telling that it's probably not possible.
That's right.
Yeah.
Yeah. Yes.
More examples.
There's more examples. Yeah. So this is also another debate: is how good are we? Do we have any system that helps us to differentiate a deep in submucosal invasive cancer from a T2 cancer? And we don't have optical classification system to differentiate. It's even, I think, more difficult. And I think it's impossible, if you look at the histology, to optically see the difference between a cancer that is touching the muscle or just turned into the muscle. How can we, with any system, not MRI, not optical system, we'll see the difference? I think the only way is histology. Yeah.
So the surgical principle, in doubt, take it out.
If we can find ways of doing that safely, I think that's is the way to go. Yes. Yes. Also, I think it's very important that we realize that depth of invasion itself, I mean, that was the big boundary, right? Because if something looked maybe deep invasive, then we should stay off. I mean, that's what the guidelines tell us. But now that we have data that depth of invasion is not a predictor of lymph node metastasis, and there's a substantial risk that it will be a low-risk cancer, then we have, I mean, it opened the door for local excisions. Yeah.
So it's the other risk factors. It's not the depth of invasion.
No, it's more the tumor biology and not the depth of invasion.
As the small one and the big one showed very clearly.
Yeah.
Okay, so we are now convinced that local excision can do the job, but if we go into the battle, we have to have the best weapons. We'll talk about that a little bit later, but there's a lot to do. You have this endoscopic diagnosis. What do you do? Are you believing in EUS? It's a mean question, but do you think EUS helps in that discrimination?
To be honest, I'm not a believer for EUS to make the differentiation, because if you look at the histology images, I can show you that often there's a tumor reaction underneath the invasive front. There's this desmoplastic reaction, and I don't believe any modality can see the difference between a tumor touching the muscle or just growing into that. I just can't believe MRI or EUS would see the difference. I mean, I think we must be able to differentiate deep T2 from superficial T2, or from deep submucosal invasion. But we should be able. But the difference between a deep SM or a early T2, just like we cannot see the difference between high-grade dysplasia and early submucosal invasive cancer, not by any means, and even pathologists have difficulties in.
Well, there are people stating otherwise, but I'm the wrong partner to speak about, because I started with EUS long time ago, and I saw the decline. So I think a lot of us, like ourselves, we're doing EUS, but then we don't really believe in it. So it's a part of the puzzle.
Yeah.
But so what is same for CT and MRI, right?
Yes, I think so. Although I think there are some, like Gina Brown is a very famous UK radiologist, and she did a nice study showing that if there is a 1 millimeter preserved muscularis propria underneath the invasive front, it really points us to the direction it's not a late T2 cancer. So it nicely selects cases for local excision in the intermuscular plane, for example. And it's very easy if you use that standardized reporting system to train other radiologists, and showing a very nice accuracy of 85% in selecting the right cases and preventing, for example, a T2, deep T2 or more. Yeah, I think so. There's
it's challenging.
It's still challenging,
but you're doing all of these tests, of course, for study reasons or whatever, or because we have to be cautious if we go into a new area.
But we still have limitations.
But it's not so helpful at the end.
No.
And
so
then
we
you
have
decide
to
on the basis of what? Of the
yeah,
atmosphere of the day, or how you feel?
First of all, all those cases are discussed in the MDT. But together we look at the endoscopic images. We look at the MRI. We consider also the location of the lesion, which is very important. For example, because we know that we have to accept a certain percentage of T2 cancers when we do local excisions on optical deep invasive lesions, and we know that from EFTR data, and we see that in our EID data, that a significant proportion, up to 30%, is a T2 cancer. But is that problematic if you would still be able to remove it radically? I don't think so. And I think, I think in the future, if you ask me, I think we will also be able to treat T2 cancers locally with adjuvant regimes, right. Of course. But that's maybe. For the future.
So for people trying to make those decisions, you're still doing these tests, but then it's a mixture of gut feeling, maybe size. Also, if you touch the lesion, if it's very hard, it can't be moved, etc., etc. So there are certain stopping points, right? So in which patient you would not do either surgically or you with your technique not
do EID,
do a local
for
resection?
Example. Yeah, if it really looks like a deep T2, if you have on MRI clear deep invasion beyond the muscle, we won't start, of course.
So, but the trade-off is, if I understand you correctly, your stopping signs are such that if the stopping signs are positive, they are probably correct in 90%. If they are negative, you still have to accept an understaging rate of 30%.
That's right. Yeah, that's right.
Okay.
Yeah.
Good. So that was a fantastic first episode. We end with a cliffhanger, because we want to do in the next episode which techniques are suitable from the endoscopic point of view. Thank you very much, Barbara.